Welcome to the Listen Up Podcast, where we explore hearing loss, communication, connections, and health.
Dr. Mark Sims here. I'm the host of the Listen Up Podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to effectively treat their hearing loss so that they can connect better with friends and family and remain independent. The reason I'm so passionate about hearing loss is I lost my brother Robbie twice, first to his hearing loss, and then again when he passed away. I only care for ears. I'm the E of ENT, or the ear of ENT. I've taken care of tens of thousands of patients with hearing loss and performed over 10,000 surgeries during my 20-year career. I'm the founder of Listen Up Hearing Center. If you want to learn more about that or my book, which is Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss, you can go to listenuphearing.com. That's listenuphearing.com to learn more. I have a great guest today. I'm really excited. It's Dr. Keith Darrow. He has over 20 years of experience in hearing healthcare, and now his single focus is on teaching people how to prevent cognitive decline and dementia. Dr. Darrow is a neuroscientist, clinical audiologist, certified dementia practitioner, medical researcher, and author. Dr. Darrow believes wholeheartedly that hearing care is healthcare and that hearing loss can have a significant impact on an individual's personal, social, economic, and cognitive capacity. It's a great guest. Excited to see him. I've had a lot of guests to say, hey, have you had Dr. Darrow on? So now he's on. So for those people who, because I always ask people who are other good guests, and he's been mentioned multiple times. So we're finally connecting. Keith, welcome on. Mark, call me Mark. It's easier from a conversation.
Absolutely. No, Mark,
welcome.
Thank you so much for the very kind introduction. I'm excited to be here. I've certainly been following your work for many years, and I just think that what you're doing is fantastic. I think the more of us that bring awareness to the treatment of hearing loss, what it means, and perhaps even the consequences of untreated hearing loss, I think that's really important. So I think you and I share the same vision. We go about them in different ways, me from the audiologist side, you from the ENT side, but I think together we make a killer team, Mark.
Agreed. So tell me a little bit about how, once upon a time you were Keith Darrow, and now you ended up here. So tell me a little bit about your course.
Geez. How much time do we have, Mark?
All right. Well, people only watch so long, Keith.
So I will, in all seriousness, I will make a long story very short. And I think because I think people will relate to it. And what I mean by that is I was not a straight A student by any stretch of the imagination. Thinking back to grade school, high school, I was not top of my class. In fact, if I'm being really honest, I was kicked out of high school not once, but twice.
Wow, good
right?
for you.
So the reason I say that, and I'm willing to share that, is because when I got to college, I found something I loved. I found something that put so much drive and passion in me that, I went into college thinking 4 years and I'm done. Well, It went from 4 years to 2 more for a clinical master's to another 6 years for a PhD. And when I was done, I didn't even want to stop, but that it was just time to grow up and get a real job, right? So It's just that message of when you find something that you're passionate about, it really may sound cliche, but it's true. And I found hearing healthcare. I found my calling, and I've tried to soak in as much as I can from within our field. I have many ENTs, neuro-otologists that I consider good friends that I rely on. So I believe together we have a much bigger impact.
Sure, I agree 1,000%. And so you did neuroscience research for your PhD, is that right?
That's right. Yeah. So I was in it was a joint program at both MIT and Harvard Medical School, the School of Health Science and Technology, where my PhD was in neuroscience. But given my background, it was clearly focused on the ear. And actually what I was most intrigued with was not only how the ear connects to the brain, but in reverse, how the brain comes back and communicates with the ear, right? We always think of like nerves as traveling in one direction. Well, most of our sensory systems actually go both ways. And there hasn't been a lot of work understanding how the brain can influence the ear. And so that's where it started. Very fortunate enough to publish a number of papers on that research. Some were in as high as Nature Neuroscience. So we did a lot of great work uncovering not only how the ear protects itself from noise, but also how the brain can sort of monitor and regulate output.
Yeah, no, I was looking on, snooping around on PubMed. I think you have well over a dozen scientific journal articles in that space. So you were doing that as a neuroscientist. I assume you got your PhD, and then what did you do?
Well, from there, one of the things I skipped over during my journey was I met a professor at the University of Massachusetts in Amherst. And I remember like it was yesterday, she said to me, first day I met her, we were walking across campus together after class. She said, "Oh, so what do you want to do with this major?" And I said, "Well, I want to teach." And she just looked at me like, "Well, what do you mean?" I said, I want to teach. I want to learn as much as I can. I want to be a practicing audiologist. And then I would love to come back and teach like you do and do research. So to answer your question, when I finished the PhD, I was then at Northeastern University, clinical faculty there. I was also doing some research. I eventually moved out to Worcester State University, became a tenured full professor there. So teaching is really one of my passions, not only the next generation, but I look to all of the, dare I say, miseducation or misinformation that's pretty rampant within the field of audiology and hearing healthcare, and try to correct that, try to really apply evidence-based knowledge to what clinicians are doing every day.
So that's a great segue. So what things would you say are some of the larger broken or misperceptions within the audiologic community right now? And let me take that back. It's not the audiologic community. It's the hearing healthcare community.
Yeah. No, definitely. And I think you asked me this to get me in trouble, but I'm going to answer it anyway.
No, I didn't want to get you in trouble, but it's a segue.
No, I'm just kidding.
Yeah.
Look, there's a lot of issues. I think really one of the things that I'm most sort of passionate about, and that I will gladly hop up on my soapbox here, is the audiogram. The thing that probably drives me the most insane in our field is the misinterpretation of the audiogram. And so I'm sure you know this, right? But the audiogram is a very reliable metric, meaning you can test it 100 times in 3 days on the same person, and you're going to virtually get the same answer.
Right.
Which is different from, is it valid? Is it a valid metric of damage in the auditory system? Which has unequivocally been shown 7 times since Shuknik that the audiogram does not faithfully, or not even close, represent what's actually happening in the ear. And so, one of the most recent publications that came out of the lab that I used to work in with Dr. Liberman and Dr. Stéphane Maison showed that you can have up to 80% loss of ear to brain neural connections, those auditory nerve fibers that everybody loves and, goes gaga over. You can have 80% of them missing and still have a normal audiogram. So for me, probably the biggest concern I have is our interpretation, where people say, "Oh, you have normal hearing. Therefore, your complaints about background noise, your complaints about tinnitus, your complaints about inability to communicate are not valid. I can't help you. Come back next year."
Sure.
Right. So that's probably that. And the fact that, we rely on the audiogram and then word recognition score, which again, in that paper that came out this past year, was shown you can lose up to, I want to say the number was around 60% of ear to brain neural connections and still have a perfectly normal word recognition score. So the tests we have, we've got to continue to push and further evolve the diagnostic evaluation we have so we can really help treat more people.
So what would that be?
Well, I for starters, so that's a great question. And I think there's 2 ways to answer that. What can we do right now? And then what does research have to get us to?
Sure.
Right now, I think at a minimum, we must involve cognitive screenings, right? With new papers coming out every day, including subclinical hearing loss being correlated to risk of dementia, right? So I think that cognitive screenings are important. I think every patient should have otoacoustic emissions tested, which you and me, it's like, what do you mean? People aren't doing that? Yeah, believe it or not, I think it's 75% of hearing healthcare providers are not measuring like actual function of cells in the ears. I think that we can do high frequency audiometry. The fact that somebody had this grand idea of let's ignore the second half of the cochlea as if it has no bearing on our ability to communicate or hear in background noise. I think that's pretty obscure and pretty, limiting as to what we can do. So I think there's things we can do right here, right now. And then like, if I have my magic wand, I would love if we could do a reliable, dare I say, a quick ABR, something where we could reliably
the integrity of the whole conduction system.
Exactly. Not just, right. Let me ask you, because you've seen, I don't know, probably a million patients. When's the last time somebody came in and said, doc, I can't hear beeps?
No, I agree. I mean, I would, my take on this is we need to do more functional testing rather than diagnostic testing. And so that means simulating real life testing, hearing and noise and those types of things. Interestingly, just out of curiosity, if somebody has a abnormal audiogram, would you still do OAEs, or you already know there's cochlear issues, right?
So that's great. So we actually, as part of our protocol, and this is what, sometimes I kind of scratch my head and I'm like, I can't believe we've amassed such a large community at AuDExperts, which is our coaching and consulting, where people are sort of coming to us saying, hey, we want to learn how to do best practices better. We want to provide more value to our patients. And I sort of start with the basics of, let's talk about your testing protocol, right? Yeah. And there are others. We'll talk about marketing, we'll talk about mindset, all that other stuff. But in terms of testing, what are you doing? And then you find there are so many holes. And the one that I think is the easiest to fill is, before the audiogram, can you assess function of the cochlea? And I really do. I look at the otoacoustic emissions as, is there or isn't there damage? To me, it's a yes-no test. It's yes, there's damage. No, there doesn't appear to be any damage to the cellular function in the ear. And then
I'm just trying to triage it, right? So if the audiogram demonstrates cochlear damage, you probably don't need it as much as you do in a normal.
Oh, sorry. You asked it the other way. I got you. Look, it's part of our protocol. We always do it first. Sure. And given that it's, 45 seconds for both ears, we just do it anyway. But to your point, fair. If the audiogram, I've never found a case, unless auditory neuropathy.
No, I'll be honest, I don't know a case where the OAEs were present and the audiogram was out where there wasn't.
Yeah, exactly. Right. But for the average person, seeing the average patient with age-related hearing loss, yes, if the audiogram shows a problem, I think the interpretation needs to be the problem's a lot bigger than you think, right? So using the word normal up to 25 dB is egregious, because Fletcher told us 100 years ago that normal extends up to 13 dB, not 25 dB. So that was the original studies.
And the research is showing even in that range that there's, functional capacity issues, even if you're lower part of normal.
Exactly. So, and I think you're right. And I just failed to say it before, but in addition to the diagnostic testing, for which we can do more, there has to be a lot more functional testing. And I think until we get to a real valid metric, and this is where science meets art. You have to account for your patient's symptoms. You have to account for those, listen to them, and still offer to help them. Because I'm sure you've seen it with, audiologists in your clinic. There are patients that, life-changing benefits from treating hearing loss, even at 15 or 20 dB.
Yes, very much so. And actually, interestingly, they tend to be some of the happiest patients.
Absolutely.
Which is kind of an interesting, observation. Yeah, no, I agree 100% in terms of that. One of the things that I find intriguing is the fact that the surveys that people love to administer in terms of impact to hearing loss, the research shows that it actually doesn't correlate to audiogram. Meaning, your percept of impact to hearing loss doesn't necessarily correlate to what the audiogram shows as your hearing loss.
But I bet if there were a study done that related the perception of hearing loss and neural degradation, I bet there'd be a much tighter correlation, right? So the audiogram is just, look, I'm not suggesting to throw the baby out with the bathwater. I'm like, people look at me and they're like, so you don't do an audiogram? No, I didn't say that. We do an audiogram, but A, we always do interoctaves. B, we always do extended high frequency. And C, we really only treat it as a tool to then program technology when we treat the hearing loss. And in addition, we use it as one of our metrics of increased risk of cognitive decline, right? Lynn told us very clearly, for every 10 dB of loss, your risk of cognitive decline and dementia increases by another 130%.
Yeah, no, I mean, it's all out there. It's just, how do you see? To me, I think the issue is how do you frame the discussion to get people to understand it? I mean, the things you're talking about are, very important things, but translating that into a conversation with a patient is not easy, right?
It's not. And that's probably the biggest question I get, right? So one of the things that we do every year, shameless plug coming, we do our neuroscience bootcamp, right? And I just want to introduce you to why we do this, right? So for starters, there's a hands-on brain lab, which helps reorient the hearing healthcare provider with what they do every day, which is treat the brain, right? Sure. Like, we have to stop thinking that we treat the ears. And I know you know this, we treat the brain.
Right.
But then we dive into, okay, let's all come together. And I mean, granted, I feel like I take my PhD 6 years and squeeze it into 2 days. I feel like I need to confer doctorates at the end of it. And so 2 days, it's squished in of teaching the actual neurophysiology, the actual pathophysiology of what happens in the ear as we get older, what it means when your patient says they have ringing, when it says they have difficulty in noise, what's actually happening inside. And then what we're really starting to even transform our own boot camps into is training the providers how to then use empathy and science to convey this message to the patient, right? Because we can't just dump knowledge on people and expect them to change their behavior and how they speak to patients. I feel like the people who come to us say, I kind of get it. Yeah, I'd love a little bit more science, but my real problem is implementing it and educating my patients so that they understand that this ain't just a hearing aid.
Right. Well, it is, but with a constellation of other things associated with it to rehabilitate them. But I understand what you're saying.
Yeah.
And so no problem with talking about it. So you have your neuroscience boot camp. When does that occur?
So that's in May every year. So regardless of when you see this, there's one coming up in May. So I feel like I feel like my goal is to try to give back to hearing healthcare providers. Not only am I teaching at the university, not only do I work in my own clinic, for which we actually have clinics that are now everywhere from St. George, Utah, to Dallas, to Phoenix, up to, Massachusetts. So that's one way I can impact patients. But another way of giving back is through the Neuroscience Bootcamp and through our other live events. So I am also, you mentioned this, a certified dementia practitioner. Right. But during COVID, I actually doubled down and I became a certified dementia practitioner trainer. And in just the last year, over 350 people have gone through this course. Now, the course is actually designed for more of the social
allied
worker,
health.
Right, for allied health, for people that day in and day out. But we've sort of adjusted the content. I mean, I stick within the lanes that I have by the National Council to certify people, but really taking the scope from the hearing healthcare provider so they feel like they get it, right? We hear it all the time, oh, hearing loss and cognitive decline. What does that mean? How do I educate my patients? How can I be a resource? How can I talk to them about something other than hearing, like diet, like isolation, like physical exercise, right? All the other factors that potentially reduce the risk of cognitive decline.
Yeah, no, I agree. It's just it's a big bite if you really look at it. I mean, there's a lot of stuff to get people to cover. So it's a big bite. I mean, one of the issues I think out there is if you do cognitive screening, it's not really clear exactly what happens with that positive cognitive screen. So what do you guys do as a general practice?
So our general practice is to perform the cognitive screening on day one, right? Now, Now look, I don't, this again would probably take quite some time, but we have an entire process we've built where our patients actually come to our appointments with certain expectations, meaning they know there's going to be a cognitive screening.
Sure.
They've learned about the connections of hearing loss and cognitive decline, how hearing loss increases the risk of falls and tinnitus. We do a ton of upfront educating because, we don't really believe anybody's looking for a quote unquote baseline. If people call us, they have an issue, they have a concern. And so we want to educate them before they come in. So as part of our protocol to breeze through it, before we do any of the auditory testing, we want to understand, using the Cognitive You Thrive technology, we want to understand how our patients, or I should say our patient's current state of memory, executive function, visual spatial memory, processing speed, right? So there's two ways to look at this. One, if there's an issue, we will forward that along with the patient and we will get that information to the primary care doctor. I will tell you 99.999 times when there is a, say, negative outcome or the patient doesn't do well in the screening, the patient will shake their head and say, I knew there was something wrong.
Sure.
Right. Or the family member will say, I knew something was going on here. Right. So it's a tightrope to walk because you never, ever want to convey to a patient, you have dementia, right? Like you should lose your license and be locked up if that's the way you talk about these things to your patients. So we empower them. We talk to their primary care physicians, and then we'll actually do follow-up testing. So as we begin treatment, there's a lot of documentation in the peer-reviewed literature that shows cognitive scores increase with treatment. And so we'll try to track that throughout the treatment program. So that's, I guess the short version of how we've incorporated into our practice. Oh, I'm sorry. And the other thing, we also incorporate the finding into our rehabilitation program. Sure. So what do I mean by that? A lot of audiologists have a patient in front of them, and on day one, they want to show them the hearing aid, teach them to put it in and out of their ear, connect it to their Bluetooth, show them how to use the app, show them how to push the buttons. You can't do that if your patient has a known memory and processing issue, right? So you're actually informing how you're going to space things out, how you're going to treat your patient, because now, we've got processing and memory issues. Maybe we'll get through putting it in and out today. And then next time we'll do it so you've got to make use of this information, not just do a screening and move on.
No, I agree. It's just interesting because, you have to be able to deal with the results, right? So, I think the cognitive screening is fine, but making sure if there is a result that demonstrates a mild cognitive impairment, whatever you want to define it, you have to be able to do with it. And then, if you can demonstrate change, I know that there are studies that demonstrate change. I'm not sure, maybe I'm not knowing the literature, that there are studies demonstrating that tool demonstrates change after treatment.
No, you're 100% right. So it's a weird, at least the tool that we're talking about is in a weird space.
The tests that people do to demonstrate cognitive improvement are much more in depth than what the screener.
They definitely are. And so I know
we do the MOCA. We don't do
perfect.
We do a formal MOCA, which for the listeners is a little bit of a more hands-on formalized training, because that has reproducibility and measurability. But even that is not what the test like. So when the literature says you get your hearing loss treated, your cognition gets better, it's not a better MOCA. It's actually a substantially more in-depth testing.
Yes, I agree with you 100%. And I think we're still at least with the tool we're using, I think we're still in the thick of that. So what we do know is that there's an incredible amount of both validity, because it's been matched against MOCA and slums and all that, but it also has a ton of reliability. So if you just take the test every day, there is actually not a learning effect. They built that in. This is my understanding of literature. And so if the score changes, it might imply a significant change up or down. And I think that right now, I know there's a ton of research being done on that, but I agree. At the end of the day, Mark, it's still a screener. Right. So by no means can you use it, say, hey, your score's improved, you're now out of the woods for dementia. Like, no.
Well, I mean, and as you know, the Lancet article said hearing loss is the most modifiable factor, but there are obviously unmodifiable factors, which are huge, your genetics and those types of things.
60%,
Right.
60% of the risk, right?
Right.
Absolutely.
Is unmodifiable. And then there are other modifiable ones that perhaps people don't address. So it definitely is a huge part of it, but it's not, it's a linchpin, but maybe not the keystone, if that makes sense.
Yeah, no, and so that's another one of my messages that I wholeheartedly believe in. So you said it earlier during the bio, right? The impact that hearing loss has, because we have to address our patients' physical, social, emotional, and cognitive health. And if you think that's just treating hearing loss, and I also think that's not just our job. I think it's our primary responsibility. But I think if there's a patient sitting in front of us with diabetes, they need to understand not only does that increase their risk of hearing loss and how that may factor in, but it also significantly increases their risk of cognitive decline and dementia. Look, it's great if their primary care doctor told them. It's great if their diabetes doctor told it. It certainly ain't going to hurt if a third person lets them know. So hopefully they can start to modify other behaviors, whether that be increase physical activity or change diet, change sleep, reduce alcohol, all the things that are on that list. I agree. We don't know this for a fact, but I believe in my heart, which fights with my brain a lot, that there's got to be a cumulative effect if we can address more than just one of the 12 modifiable factors.
Yeah, I don't disagree with you. I think the other argument is we know that there are impacts on dementia, and if we aren't able to reverse it, you still are better connected, functioning better in noise. So all of the upside from a hearing point of view is still there. So
exactly,
you'd be hard pressed to say, well, you're not helping the patients because their dementia is not getting better. Well, but they're hearing better, they're performing better in noise. There are all of these things that you get. That's kind of the cherry on top, if that makes sense.
Exactly. Yeah. Find me. Right. I'm sure somebody's going to argue and send me an email where they found me a case, but basically find me a case where treating hearing loss is a bad thing. Right. It doesn't really exist. So again, it's not about making false claims. It's about, what do we know? We know treating hearing loss has the potential to reduce the risk of falls, reduce the experience of tinnitus, reduce the risk of cognitive decline. And you know what? At the end of the day, we also know that it increases quality of life, relationships at home, ability to process. So there's no downside, right? That's the way I sort of look at it. I have this very optimistic approach. And I feel like together, people like you and I, we have to just continue to shout to the masses, because we're in a field where 80% of people living with this chronic medical condition do nothing about it. And that has to change.
Well, I think that's one problem. I think the other issue is many of the people who actually have treated it aren't appropriately treated. And I think that's a huge problem.
Can we have another podcast just about undertreated hearing loss or poorly treated hearing loss? Because that's a huge problem. I actually think that's a bigger problem, personally. I think that's a bigger problem, because now, imagine, Mark, if every patient were treated properly.
Correct.
What sort of ripple effect that would have? Imagine there were no naysayers who went to their audiologist or hearing healthcare provider, talked the provider into selling me the cheapest thing you got. They now hate it. They put it in their drawer and they tell every friend and family member that hearing aids suck. Excuse my language. But that ripple effect is out there. We have to change the conversation, but it starts with doing better testing, more thorough testing, providing more value, and never compromising on treatment.
Yeah, I mean, so I actually think that poor experience is the biggest obstacle to penetrance, personally. I think that if people they come in that they don't want hearing aids because they've never talked to anybody that's actually had a positive experience. And so that to me, I know there's other mindsets that it's price. So for instance, the over-the-counter legislation is really a response to price being an issue. I mean, I think it is an issue, but I don't think it's the issue. I think it's poor peer experience is by far the largest inhibitor of the other 80% getting their hearing loss treated.
Look, Mark, if price were the issue, in places like Denmark, where everybody knows somebody who works at a hearing aid manufacturer and they're completely free, everybody over the age of 60 would have hearing aids. But you know what?
I agree with you 100%.
Their penetration is only about 10 points. Yeah, the same. Some studies say maybe it's 10% higher. So you know what that means? That means there's still 70% of people who don't care about price. Right. And you just hit the nail on the head. I think that not only do we need to do a better job, but we need our patients to be better advocates only if they get better treatment. Because that's the deal, right? They'll refer us if we do a great job.
Well, but our language betrays it, right? So what do people say when they say you have a hearing loss? What does the primary care doctor or what does their family say? They say, go get hearing aids, right? Not get your hearing loss treated. They say, go get hearing aids. And so when people do go get hearing aids with the absent appropriate treatment, that's exactly what feeds it. And so to some extent, that might be one of the negative ripple effects of over the counters is that. Oh, definitely.
That's definitely going to come in the next few years. We're all going to see people coming in with their broken over the counter hearing aid saying, the 16-year-old guy at Best Buy in his blue golf shirt, he wasn't able to help me. Well, duh, of course he wasn't able to help you. Right. So.
Well, how do you teach our peers to communicate that?
One of the pillars at AuDExperts is mindset, right? So I think we have this, the way we approach hearing healthcare is we've got to change our marketing, right? We can no longer be, get a free turkey if you get a hearing test. That just proves that we're retail and we're trying to sell hearing aids. So we got to fix marketing. We have to fix the way we treat our patients. And we also have to fix our mindset. And so I think our mindset of what our true value is, Mark, the best compliment I ever got was from not even an audiologist. It was somebody who owned a private practice. He came up to me at a conference and he said, you know what? For the first time ever, now that I hear you speak, I feel like what you're telling me and the way you treat your patients is that the widget is like 10% of the value and 90% is in everything else you do. Right. And most hearing healthcare providers they rely on the widget. It's the widget's fault. The widget will fix it. I got to send in the widget. I got widget. Right. And we don't elevate ourselves as the trusted authority for all things hearing healthcare.
No, agreed. I actually think you could argue, even if somebody showed up with a widget, you would charge them the same.
Yeah, I'm with you. I'm with you.
Right. Because they would have to, because all of the care that you would need is substantial relative to the actual technology.
So I think you just hit the nail on the head. And that goes back to your question that I feel like you're hitting me with over and over. And I love it. I say that in a good way. We have to educate our own patients. We have to educate the public. We have to educate the MDs to stop saying things like, oh, you have hearing loss, go get a hearing aid. Or the biggest pet peeve, you have tinnitus. Sorry, nothing we can do about that.
Right.
Like there's a lot of misinformation within our own field. And so we have an uphill battle. And I feel like some days I wake up and I'm like, you know what? Life would be a lot easier if I just owned a pizza joint. And because everybody loves pizza, right? But no, I think together we will rise to this challenge and we will forever change hearing healthcare and the perception of it.
No, I don't disagree with you. I think it's, to me, the biggest challenge is figuring out how to, I think that the practices and the knowledge is there. To me, the hardest thing is how do you communicate that to patients? I think that is by far the biggest area where the gap is right now. And, as much as it's not my physician colleagues, it's peers, and it's actually audiologists say too. I have students come into my practice and put in the assessment of plan hearing aids if the patient wants them. And so the concept is I don't really understand, what the want has to do with the fact that you have a medical problem called hearing loss, right? I mean, if basically,
I love it, Mark.
Let's just acknowledge nobody wants hearing aids, right? I mean,
Exactly.
There's nobody says today's my lucky day, I'm going to get hearing aids. What they want is better communication and hearing. And the means to do that is getting appropriately selected and fitted hearing aids to be able to get to that outcome. And
so that's like step one, right? And in my first book, Over This Shoulder, Stop Living in Isolation, I laid out the five reasons why people tend to avoid hearing healthcare. And
right.
If I remember correctly, number 5 was everybody hates hearing aids.
Right.
So if we accept that fact and we can convince them, not with a widget, but with the importance and the benefits of treatment, and so they understand that you really should not live without this. Dare I say, cannot live without this, right? So, and to your point, we do a lot, right? So we have the Neuroscience bootcamp, we have the certified dementia practitioner courses, and thrown in between, my team runs treatment bootcamps. Those are like, seriously, that's like, boots on the floor. That is getting down and dirty. It's 2 days of role play, of going through case studies. It's learning how to talk to patients, what words to use, letting people fumble, in private, amongst peers at least, and then fix it. So when you go home, because you're right, because it's one thing to have the knowledge, it's another thing to be able to implement it. And so we do firmly believe that implementation is always the next step. And so that's what we do at we've got regular treatment boot camps, advanced treatment boot camps to help providers actually implement all this, great knowledge.
Yeah, this is great. Well, this has been great, Keith. Question I always ask people is what's your favorite sound?
I should have watched, and I should have asked friends. So I was more prepared.
I actually tell people that in the warm up, but you were like, no, let's go. So because of exactly what happened to you. Honestly,
Mark, I would have been thinking about it the whole time, and I wouldn't have been able to answer any of your questions.
No, it actually gets people set, but it's okay. I think.
All right. So I see what I want to say, because I feel like everybody says their children's laughter, right?
That is true.
But really,
somebody told me a Porsche 911.
What was that?
Somebody told me a Porsche Carrera 911. So there
are. Okay. All right. Fair enough. No, honestly, to me, it's, again, long story short, without getting too personal, I have tried to build what I consider like a fort or like a mecca. So my home, my sort of castle where everybody's always invited, where the kids always have friends over, and probably one of my favorite things, probably the best thing I ever did for my family, was built a pool in my backyard, and the sounds of summer when my kids are out there with 10 friends from the neighborhood jumping, laughing, that probably brings me the most joy of any sound. So
yeah, that's a great source of joy. So everybody, this is Dr. Keith Darrow, clearly passionate advocate in the hearing health field. Keith, if people wanted to get a hold of you, how would they do that?
Look, I think the easiest way is to go to drkeithdarrow.com. If you are a private practice owner looking to be part of our community, AuDExperts.com. Join the community. We're over 100 clinics from Alaska to Canada to Florida. We've even gone international, so would love to help you. Mark, thank you so much for your time today.
Sure, great. This has been a great episode. Thanks for coming on, Keith.
Absolutely.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.